everyone. I'm Patricia Kaufman, the co-founder and communications director for the CLL Society. Welcome to our fourth COVID-19 virtual community meeting. This meeting will be focused on the challenges that our CLL patients and their caregivers are experiencing as they manage reentry during the COVID-19 pandemic. At the CLL Society, we are dedicated to delivering credible, up-to-date information of specific interest to our CLL patients and their caregivers. The COVID-19 pandemic has made it more critical than ever that we acknowledge that we are all in this together. We believe that smart patients get smart care, and that is at the core of all of the education and resources that the CLL Society brings to you. The format of this virtual community meeting is designed to present your questions directly to our expert panel. Many of you have joined us for our past virtual community meetings on COVID-19. However, if you have missed any of them, don't despair. You will find all of them on our website under Archived Educational Activities. We would like to thank AbbVie and AstraZeneca for sponsoring the CLL Society's COVID-19 virtual community meeting number 4, titled Managing Reentry. Thank you. At this time, I would like to introduce our moderator, Dr. Brian Kaufman, Executive Vice President and Chief Medical Officer of the CLL Society. Brian.
Hello, everyone, and thank you for joining us from across the country. We're excited to be here, and it's been a while since we last did one of these, but I thought it was important to wait a few weeks until we had more data. For those of you who attended prior meetings, we were flying through a lot of data-free zones when we talked, and there's still a lot of data-free zones, but we have some information that we can share, so we wanted to wait for that. Thank you, Patty, for the introduction. I'm going to introduce our speakers, starting with Deborah Stevens. Debbie is an assistant professor of hematology and heme malignancies at the University of Utah, the Huntsman Cancer Institute in Salt Lake City. Dr. Shadman is returning. He's an assistant professor in medical oncology at the University of Washington and does a ton of research in both cellular therapy and CLL as part of the Seattle Cancer Care Alliance. Dr. Kimberly Hansen is joining us for the first time. She's an infectious disease specialist who focuses mainly in immunocompromised patients and also has a background in clinical microbiology and directs the microbiology fellowship program at the University of Utah. Dr. Joshua Hill is returning, an assistant professor. Dr. Hill also deals with immunocompromised patients at the Fred Hutchinson and is very interested in vaccine development. And Dr. LeClaire has attended all of these as faculty, and Dr. Susan LeClaire is professor emerita at the University of Massachusetts. And her area of expertise, besides forensic DNA, which we're not going to get into today, is understanding how lab tests are done and how those apply to the COVID situation and to CLL in general. So here's our agenda, and we're going to try to stay on time here. We're going to have some panelists' comments, but the bulk of the meeting, as you're going to see, is going to be your Q&A, and please continue to send in those questions. There will be some poll questions that I'll be asking at the beginning and again at the end, and we will be asking you to review this for us, so that's very important that we get those reviews in. So our next slide is pre-questions that we're going to ask you to take a look at. And if you look through this, you're going to see that there's actually a series of questions here, a total of 5 questions. So we'll give you a minute or so to scroll through these and answer them if you can, and you'll be seeing these questions or similar questions again at the end of the slide presentation. Okay, so interesting to see more than a third of you are attending your first meeting here. So we're welcome to that, and welcome to the 2/3 that are returning. It's interesting that people have a good sense of how to handle precautions. 88% have a sense of that. And this is, I think, something the panelists will be interested in discussing. People seem to be spread here in terms of how they're going to do. It's interesting that 40% say that the current pandemic will have no influence on their therapy decisions. And I'd like to hear from the medical professions about how they feel about that, while others see that it's, 17% are saying, I'm going to stay with what I'm doing. And interesting here, makes me less likely to have lab work done. 16% will revisit that. The greatest fear is getting COVID. I think I could understand that, and hopefully we'll address that. But there's also people worried about returning to a normal life and other concerns. And then looking here again, the people are not making changes yet. The majority, not a plurality, 43% are not making changes, where more than a quarter are increasing essential activities outside of the house. So I'd be interested in the feedback from the faculty as we go through that and see if that changes at all.
So first of all, I want to say thanks to the CLL Society for inviting us today. I think this is a really important topic, getting back to whatever normal life looks like in the setting of this corona pandemic. And I think in my clinic, I'm getting a lot of questions about this. And so I think this is a great forum to be able to ask questions in this setting. I'm going to start by just giving some really general notes to start things out. And then Dr. Shadman is going to speak a little bit more specifically about CLL briefly. However, we want to emphasize that the most important thing is that you get your questions answered. So we're going to have a lot more time for questions and answers than, a traditional lecture. So first of all, as far as my general notes, most states are relaxing social distancing restrictions. And of course, I think this group especially knows that this does not mean the pandemic is over. And so a lot of questions are, why are we relaxing social distancing? And really, I think it's important to understand that the goals of early social distancing were to slow the rate of infection and keep the hospitals from being overwhelmed. This also gives doctors enough time to find good treatments for coronavirus, and it gives researchers time to start working on vaccination for coronavirus. And, at this time, a small amount of data has started to trickle out specifically for CLL patients, but until we have really detailed data, this group should assume that you may be at a higher risk of contracting the virus, and you may be at higher risk of complications of the virus. So of course, I think all of this has been hammered in the news recently, but I wanted to go over some general recommendations for prevention of contracting coronavirus. And I think hand washing, I put it in capital letters, just because I think it's so important that good hand washing is performed. And that means at least 20 seconds in warm soapy water or using hand sanitizer. Social distancing is one of the most effective ways to prevent this. As we all know, it is spread through respiratory droplets, meaning if someone spits or sneezes into the air, you can be infected by it. I still think at this time, especially this group should, if possible, limit activities to groups of 10 or less people. Make sure you're wearing a mask and ask your loved ones to wear a mask around you as well. Of course, you've probably heard that these droplets can pass into your eyes. And so if you have to be within 6 feet of someone, I would suggest wearing eye protection. People who have confirmed COVID-19, you need to avoid them for at least 14 days after the last symptoms. I think during this time, telemedicine is appropriate if possible. But if you have new or rapidly worsening symptoms, you really should consider seeing your doctor in person. Because although we try to do the best job we can over telemedicine, it's difficult to really assess everything remotely. A lot of questions for my patients have come about receiving IVIG infusions, and this is intravenous immunoglobulins. If you're already receiving these infusions, I think you should continue to receive them because it's possible they may provide some protection against the virus, although again, there's little data about this. If you're not currently on these, there's no reason to rush out and get on them, specifically just because these infusions are not without potential complications. And insurance companies have very strict regulations of who is allowed to go on these infusions. And they typically include a low immunoglobulin G level, variable, but at least less than 600, and then recurrent infections. And these are usually recurrent severe infections. And if you don't have that, your insurance may not cover these infusions. As far as medical prevention, there's no specific medications for prevention. Of course, you all have heard a lot about hydroxychloroquine, and really we know now that these can have serious side effects, and it's not yet proven to prevent coronavirus. And so I would be very cautious and not recommend going out and finding these medications or derivatives of them in order to prevent coronavirus. There are some questions I know that people have sent about, could vitamins like vitamin C or zinc prevent coronavirus? And of course, we don't yet have great data specifically about coronavirus, but of course, there is some data in generally preventing infection, so they may be helpful. Now I'm going to turn it over to Dr. Shadman. He's going to talk a little bit more specifically about CLL and returning from the coronavirus pandemic.
Yeah, thanks, Dr. Stevens. And I would like to thank the CLL Society for inviting me again. And, so this is an ongoing discussion. We had our first online meeting, I believe, more than a month ago. And, things have changed since then. And the most important factor is that the change of the rate of infection in different parts of the country and different parts of the world. I mean, the audience here, I believe, come from different states and even different countries. So the most important factor to remember is that depending on where you live and depending on what is the current prevalence or incidence of infection, these recommendations could vary. So, for example, when we were at the peak of the pandemic, and we were a little bit more strict in terms of our recommendations specific to CLL therapy. And for example, in Seattle these days, we've been more relaxed and kind of going back to our standard practice. So keep that in mind. But in general, there are principles that I think we should still follow. We don't know where this pandemic is going. We're not very clear in terms of the shape of the curve that we're dealing with. So whenever possible, in patients who are on watch and wait and don't have an active question or concern, I think telemedicine visit and using local labs. I mean, for us, a lot of our patients come from hours away and they drive, and we try to utilize local labs if they can have a blood draw next to their home, and we try to get the results and do a visit on the phone or using the virtual platforms. That's what we do these days. In CLL, as you know, usually treatment discussions start months ahead of time. It's relatively rare for us to have to start treatment in days or weeks. So a lot of patients can actually wait until we get to a more stable status in terms of the disease prevalence, and that's what we're doing. So if we have started a conversation about treatment around March and patient remains asymptomatic, if they have a relatively stable blood count and we can safely delay treatment, that's something that we do. However, I wanted to use an example here to make sure that we all understand that we don't want to delay treatment for a patient who really needs active treatment for CLL. So COVID-19 is important, and all these discussions and trying to prevent it and trying to do a better job in terms of managing it. But remember, we also deal with the active problem, which is CLL. I did have a patient who I first met through the online and digital platform, and just talking to him, I could tell that, you know, he had difficulty even talking to me, and he was very symptomatic. And unfortunately, he was told by his physician that he should wait until after the coronavirus the situation is resolved. And we asked that patient to come, and you know, we were able to start treatment, but it could be a very complicated course if there were a longer delay. So if there is an indication for treatment that can't wait, we should be aware, and we are able to provide treatments these days that are acceptable even in areas where COVID-19 is still very active. So keep that in mind. There's no blanket recommendation regarding not starting treatment or delaying treatment. If somebody needs treatment, we have to deal with it, and we will do it. Especially these days, with that most of the places we've passed that peak. So active discussion with your physician would be very important. We have the luxury of having number of options for most of our CLL patients these days. So most of the time when we start thinking about treatment, there's more than one option, and that's because of all the advancements that we've had in the past few years. So when possible, it would be preferred to use a medication or a treatment strategy that doesn't require infusions, doesn't require multiple visits. And this is all common sense, right? If I can start a patient on a medication that's oral and I don't need to see them every week, that makes sense. If that option is clinically reasonable for their CLL. If not, and if we have to start a different type of treatment that's more work for the patient or for the clinical team, then we will do it. But when there is an option, we would prefer to use a treatment with minimal visits and fewer visits, and to minimize the exposure to the healthcare facility. So what about patients who are on active treatment for CLL, and what should they do? So we're talking about patients who are on treatment for CLL and they don't have a COVID-19 infection, so they're not infected. Dr. Stevens kind of went through some of the preventive measures that we need to follow. I'm not spending time on that. The principles of physical distancing, hand washing, and basically these days with the tests being more available, we have a very low threshold of using those diagnostic tests for our patients who report any type of symptoms. So we get a call from our patients, any questionable symptom or presentation, we test them. Early diagnosis is important, as our infectious disease colleagues will tell you that some of the treatments that we have are most beneficial when you start them earlier. So we would like to know if our patients have the infection. Dr. Stevens covered the IVIG. We have patients who are receiving either monoclonal antibodies as part of their treatment, or as part of their treatment with novel agents or chemoimmunotherapy. Most of the time, it's safe to skip an infusion for a month or two, and it doesn't affect the clinical outcome significantly. And if it does, the risk-benefit really favors not bringing the patient back and not exposing them to long hours of infusion in the clinic. So that's what we have been doing at the peak of the pandemic. But again, these can change over time as we get away from that peak. Again, if there is a patient who's receiving chemotherapy, and depending on where they are in their chemo, sometimes those cycles could be skipped or held. If somebody is receiving or is due for their cycle 5 or 6 of bendamustine rituximab and their disease is almost gone or already gone, is it okay to stop there? Clinically, most of the time, the answer is yes. So things to consider about the active treatments that are not novel agent. And again, in principle, less frequent visits, even for patients who are, if you have a patient who's very stable on acalabrutinib or ibrutinib or venetoclax, and you see them every 2 months, and if they have no complaints and their counts and lab results have been stable, so you can probably delay their treatment or use the telehealth platform. Currently, there's no reason to stop treatment, and I saw this as one of the questions. If a patient is taking any type of targeted therapy, should they stop to decrease the risk of getting the infection. There's no evidence for that. So we continue treatment as usual in patients who are not currently infected. And my last slide, if I can have it. And what about patients who are on active CLL treatment and become infected and get the COVID-19 infection? So there we have a very patient-specific situation. So again, we don't want to make any general recommendations. So the risk and benefit of continuing therapy has to be discussed with the patient. Some of our patients, no matter what novel agent we're using, if you stop it, their CLL can become active quickly. So we have to keep that in mind and kind of balance that with the risk of getting infection. But what I can tell you, and it's specific to CLL patients, we are starting to have some data coming from different groups, really focusing on CLL patients or patients with CLL who also have the COVID-19 infection. The European group had just released some data recently, and there is a large collaboration led by Dr. Mato, and hopefully that will be published soon. And basically what I can tell you is that not surprising, sounds like if patients with CLL become infected with COVID-19, their clinical course is more complicated, and we have to deal with a more serious situation in terms of treating them. So keep that in mind, and we'll get more data, but it doesn't really change our principles. Basically, prevention is key, and everything that we have been discussing kind of goes with that. And just a last point that I wanted to make, and this is something that you may have seen in the news recently, and they're having a few questions. BTK inhibitors like ibrutinib and acalabrutinib have some impact on parts of the immune system. And as you know, with the COVID-19 infection, one of the phases that patients with the severe type of infection go through is that inflammation storm that they go through. And there were reasons to believe that these agents like ibrutinib or acalabrutinib can slow down that immune storm. We knew that from the science that we knew about these drugs. The CLL Society had actually, early during the pandemic, there was a research that surveyed number of CLL experts around the world. And even then, most of us believed that these drugs could be continued even for patients with infection. So what we have seen recently, there were 2 reports and papers that showed that in patients with severe COVID-19, if they received either ibrutinib or acalabrutinib, sounds like that immune storm was responsive to these drugs. And we saw, again, non-controlled studies, and they have to be confirmed, but at least there were some promising results in patients with severe COVID-19. Now, we can't make very strong conclusions out of it. And as I said, there are a number of studies that are ongoing right now, but at least we can, from these studies, we can say that if we have a patient who is already on ibrutinib or acalabrutinib, even if they become infected by COVID-19, I think it makes sense to continue those agents. And I think that's something that most of CLL experts believe these days. For other agents, in principle, like anything else in oncology, when you have an active infection, we err on the side of stopping the drug to decrease the risk. I think I'll stop here, and hopefully we'll get more points to cover during the question and answer.
Thanks, Dr. Shadman. I think I may be up next. So again, my name is Kim Hansen, and what I thought I would do is go over some of the more common questions I get from my patients from an infectious diseases standpoint, and focused on 4 areas where I think there is some new data out there, so we can provide more specific information that's backed up by evidence. One question is, if I think I've been exposed to COVID-19 or a patient who has COVID-19, how long would it take for me to exhibit symptoms, or when might I get sick? And we're learning now that the incubation period from the time of exposure is pretty variable. It can range from 2 to 14 days, but on average, if people are going to develop symptoms, it takes about 5 to 7 days. And this recognition is one of the reasons why the Center for Disease Control, CDC, has recommended if you've been exposed to self-isolate or quarantine for 14 days, because usually by then, if you're going to develop symptoms, you will. What we're learning now, though, with a variety of kind of larger population-based studies, is about a quarter to a half of people who've been exposed and infected never develop symptoms. And this is part of the reason why, and I'm sure you've seen this in the news, this has been such a difficult virus to contain, is people with infection are in the community and spreading it to others, but don't know that they have been infected because they don't have symptoms. For folks who develop symptoms, they also tend to be most infectious to others even before they develop symptoms. So this really gets to the importance of using masking and distancing in the community to try to prevent spread. And as been mentioned already, folks living with CLL, if you were to be exposed and become infected and symptomatic, may have more severe symptoms. We're certainly seeing on a larger population-based, epidemiologic-based assessment that older individuals and those with underlying medical conditions tend to get sicker. We're learning more about the symptoms of COVID-19. They're relatively nonspecific. Still, most people who become infected develop fever, cough, or shortness of breath. But we're learning that the spectrum of illness is highly variable, as is the symptomatology. So recent findings are some people may have diarrhea, just present with severe fatigue, muscle aches, sore throat. And you may have seen in the news more recently emphasis on sudden loss of smell or taste. And in some studies, this was actually the most predictive symptom that predicted who would have a positive COVID test, even though other respiratory viruses can cause loss of sense of smell and taste. It does seem to be highly associated with COVID-19. So when to seek medical care, I totally agree with Dr. Shadman and what he said, that really anybody with symptoms, even if they're very mild, should get tested. And it's a good idea if you think you may have symptoms that are compatible to call your clinic, hospital, your doctor in advance. Let them know you're coming, and they will tell you based on their own criteria whether you would qualify for testing. At the University of Utah, any symptoms, and we would say, yep, come on in, come get tested. The reason getting tested is important is, number one, we do have now some experimental therapies that could be given, and it does look like if they're given earlier in the course of illness, they may be more effective than waiting until later in illness or more severe illness. But it's also important for the public health. I mean, we want to identify who's infected and then do contact tracing around them to identify others who've been exposed and use our quarantine measures to try to nip additional transmission in the bud. I've also listed on the bottom of this slide some warning signs that would be emergency signs that you should present for medical care right away were you to develop shortness of breath or chest pain especially, or any altered mentation or levels of consciousness. So we're learning more too about how SARS-CoV-2, the coronavirus that causes COVID-19, how it spreads. And Dr. Stevens mentioned this as well. We really think the primary route of spread and transmission is via respiratory droplets. So these are small droplets of saliva or other respiratory secretions that come out of our mouth and nose when we talk, cough, sneeze, sing. And that really is the primary way we infect others. We know that these respiratory droplets can go through the air, remain airborne for a period, and they gradually usually travel about 3 feet from the infected individual. And this is one of the reasons why CDC and others now are saying that social or physical distancing should be at least 6 feet, because we're well outside that rim of the 3 feet of droplet transmission. You know, that's not to say that you could be exposed being further away from an infected person. In addition to those respiratory droplets, we also produce finer particles called aerosols, and they can travel further, remain airborne for longer, and are also part of the reason the virus is so infectious. We know that the SARS-CoV-2 virus can remain alive and viable on surfaces. How long it lives and how infectious it remains on different surfaces varies by the surface type. There have been some studies that suggest on metal and plastic, maybe as long as 3 days. On other things like cardboard, much shorter. But the point here is that yes, it can be on surfaces. You could potentially touch an infected surface, and then if you were to touch your face or your eyes or your mouth, could infect yourself that way. And so that's why the hand washing is so essential. And also being really cognizant of about touching your face. I never realized before this how much I touch my face and mess with my hair and do other things. And now I'm very, very careful to try to not do that. Another question we've gotten is, could I get SARS-CoV-2 from my pets? Doesn't look like that's the case, but there are some rare reports of infected individuals actually passing it on to their animals. So if you were to become infected, having someone else care for your pets during that time would be preferred. And then I'm not going to spend a lot of time on how to protect yourself from infection. This has been mentioned by 2 other speakers. It still remains important. As was said, even though the economy is open, it doesn't necessarily mean that the pandemic is ended. And in the state of Utah, actually, our cases are increasing. We're one of 10 states with a pretty rapid rise in new numbers of cases every day. So we're still very diligent about recommending the physical distancing of at least 6 feet. Being outside in areas with better ventilation may help also protect you from those respiratory droplets. The frequent hand washing, as was mentioned, soap and water. If you're gonna use a hand sanitizer, if soap and water is not available, look for hand sanitizer that has at least 60% alcohol in it. I know this group is very diligent about cleaning high-touch surfaces in your own home or in your place of work. And then lastly, masking. Masking serves 2 purposes. One is to protect you, but also to protect others were you to become infected. And I've kind of listed here the level of protection from different types of masks to the wearer. So the N95 respirators, the best, most protection. The problem here is that these masks are on shortage and they're hard to come by now. And it's really recommended that these be reserved for healthcare providers on the front line. So you may not be able to find a new N95. But surgical masks are a close second, and then after that, a cloth mask. You can reuse surgical masks. What I'm telling folks is, as long as it's not obviously soiled on the outside, use your mask etiquette to remove it without touching the front. And then I ask people just to store them in clean paper bags for a couple days, and any virus that would have been on the outside should be inactivated by that time, and you would be able to wear it again. If you're using cloth face coverings, I recommend washing those after each use and also putting them through the dryer as a way to keep them clean. So I think that's the end of my comments. I'll stop there and turn it over to Dr. Hill next.
Great, thanks Dr. Hansen for that fantastic overview there. And I know that there are a lot of questions out there that people want to ask directly to the panel. So in the interest of time, I'll try to keep this very brief. And I just wanted to present a little bit of data that just recently was published in the last week or 2, which really comprises one of the largest registry studies of COVID-19 in patients with cancer. And granted, this is a broad range of patients with cancer, but at least gives us some information to think about. Certainly these data are not meant to scare anybody, but just to give us a basic understanding of what the risk is out there. So this was a large international registry, mainly centers in the United States and Canada, and I believe Spain as well. About almost 1,000 patients here who were diagnosed with COVID-19 and had cancer. and there were no big surprises here. The median age was about 66 years old, which is what we're experiencing in the general population as well. The big takeaway, which was not a particularly surprising or novel, is that overall the mortality rate was higher than what we see in the general population, and I think that was to be expected. But again, there was a range of mortality rates depending on different risk factors. The main risk factors continue to be older age, which we know and is well established in other contexts. Men seem to be, or male sex seems to be associated in cancer patients as well with worse outcomes. Certainly having an increased number of medical problems like underlying heart disease, kidney disease, lung disease continues to be a risk factor, as it is for most of our other infections that we see in our patients. And then really it was cancer that is progressing despite treatment that was one of the main risk factors here in our cancer patients that came out. So patients with advanced disease that's refractory to the chemotherapies that they're receiving tends to identify a group of patients that are even more immunocompromised. So that seemed to be an important factor to consider here. So this is just a very brief chart. It's a little bit busy, but what I will point you to are the bars in the red scale, the kind of light pink to red. First, looking at the first panel here, this is looking at the proportion of patients in this registry who had a severe outcome, meaning either critical illness in the hospital or death. And the bars in the red are patients with hematologic malignancies, in which CLL patients were a subgroup. I'm not sure exactly how many were included in here, but in the patients that, in the very first bar there, the lightest color of red, you can see that patients with remission or no evidence of disease perhaps had the lowest risk, which was very similar to patients with solid tumors. And then it's in the patients that have advanced stages of diseases that's progressing despite therapy, where you really start to see the highest risk for this outcome of having a severe illness requiring hospitalization or death. In the next panel on the right side there, again, focusing on the red bars, which are the patients with a hematologic malignancy, you can see that there's not a big difference in between patients who are recently getting therapy or not. The highest bar there, at least looking at the absolute proportion, are patients that got cytotoxic therapies, which tends not to be the type of therapy that patients with CLL are getting. So that's the one encouraging thing, at least for patients with CLL, is that therapies generally are non-cytotoxic. And so perhaps the risk is lower there, as we might expect as well. And so I think that's all that I wanted to say at this point, and I look forward to talking more in the question and answer session. I think we can move on to Dr. Leclerc's slides about testing and interpretation of test results.
Well, most of my slides are going to be wordy, so I'm not going to be reading them. I'm just going to be kind of highlighting things on that. And the first and the most important thing that I have to say is that in the last, 75 years, so you can now call me a curmudgeon on this, our use of the English language has really become more and more and more sloppy. And so one of the problems that happened early on with testing is that, particularly once the antibody testing came out, is that people were reporting both antigen and antibody testing as COVID testing. That's all they talked about was COVID testing, without necessarily talking about which one and how to keep them separate. As a consequence of this, you may notice over time, CDC is going to be cleaning up their data, making them more robust and more accurate. So if you know someone who says, CDC changes their numbers all the time, they're actually getting better because they're making them more clean. So then what kind of testing do we have? The first kind of testing we have is, do you have the virus now? Whether you are symptomatic or not, do you carry the virus with you? And those are two basic kinds of testing. The first one is something called PCR based, and those are the specimen collections you see on TV, or you hear that your friends say that they took the swab and they put it all the way to the back of your brain. It didn't really get that way. It just felt that way. It's an uncomfortable procedure to go through, to have a nasopharyngeal, that is to the back here, of your sinuses swabbed out, and to the back of your throat, not a tongue, not a mouth, not a tooth swab, but a back of the throat swab. There is some hope that maybe a tooth and tongue swab might actually work, but right now what we need are the swabs you've all hated your physician to take from you. That PCR-based test takes a long time. there's additional time for transport and setup. And of course, in the very beginning, when a lab was getting maybe 1,000 test specimens a day, there were huge backups. It is usually a test that is based on the genome, the actual letters of the RNA code of this virus. So this is going to be very long to do. It is going to be very precise. The test itself has very few failures. There are no false positives in this kind of a test. There are false negatives due to the quality of the specimen. And for those of you who have heard me on these shows before, I will save the rant of getting the specimen collected correctly and transported correctly and having all of the information filled out on the form, because if it's not, then all of the pain and aggravation that you went through to get the specimen, it can't be used because we don't know who you are and we don't know who to give this to. So there's just a very quick overview on that. We then decided that we did not want slow times of tests. We needed answers faster. So there were rapid tests that were picked up. Some of them were excellent, some of them were not. Some of them will give you false negatives because there are a few of them who will pick up virus for all coronaviruses. Well, is that such a horrible thing? Well, 4 of the viruses that give us the common cold are coronaviruses. So is it possible that you might have a false positive mixed in there? Yes, it is. And the rapid tests are less strong, more weak on the false negatives. That is because you have to have a pretty good number of viruses taken up in the specimen in order for it to show that you are indeed positive. So you can have tests that are quick, that are easy, but when they give you a false negative, it doesn't necessarily help you with your nervousness. You should have other tests later on if you continue to get symptoms like this. And even the FDA now, who has given emergency use for a lot of these tests, is now recommending that if you get a rapid test, you should also get a backup test using the longer, slower, much more accurate test, just to make sure that those false negative results can be eliminated. These are the antibody tests, and this is changing. Actually, there's some things on here that have changed, and I only gave this to Brian a few days ago because I was late in doing that. What do you have when you get SARS, when you are exposed to it? You are supposed to, if your immune system is functional, generate antibodies. But in order to do that, 1, you need to have been exposed to a reasonable number of those viruses. If you are only exposed to 1, your immune system is going to get rid of it and just ignore it because it doesn't think it's an important thing to get. So first of all, you have to have the virus in sufficient amounts so that your immune system says to itself, this is basically an important thing, and I need to not only get rid of this, I need to generate antibodies to this. This takes a little bit of time to do. So during the first stages of your immune reactions to your immune system's reaction to the virus, you're probably going to feel worse because the immune system is just gearing up to fight this. So on the seesaw of life, the virus is in control for a little bit. How does this happen? You are going to make the first primitive primary antibody type that we make. It's going to be called IgM because it looks in a particular structure. It's usually testable, noticeable, 3 to 5 days with very sensitive testing, probably a week or so. You will see a goodly amount of IgM directed against this virus. IgM doesn't stay for very long. It's part of the big hit that goes up against these organisms. It peaks at about 3 weeks and then fades away quickly. You won't probably have any a month after you have first noticed the symptoms. The second type and this one's the more important one for certain people, is the IgG type. Takes a little longer to make, 10 to 14 days, and can, we don't know the answer to this question right now, can last for as little as a few weeks, or it can last your entire lifetime. I was one of the lucky ones at the age of 5. I had whooping cough. Yay. I still remember it. I also still have antibodies to that organism because my immune system was highly functional at the time and made IgG that is lasting throughout my entire life. We do not know yet if the antibodies to this virus will last for a few months, a few years, or your entire lifetime. The only way we're going to know that answer for sure is by watching people for a few months, a few years, or their entire lifetime. So having the antibody is great. It means that you had the virus in enough numbers that your system took it seriously and made IgG antibodies that will give you some level of protection for some time, as little as a few weeks, perhaps a few years, or your entire lifetime. Now, that's not as horrible as it sounds, because with the amount of research that's going on, it may be that if your IgG antibody lasts you for 2 years, by that time there'll be either a very effective therapy or a vaccine, so you don't really need it for your entire lifetime. So don't take this as saying, oh, I don't know, and I'm always going to be quarantined, and I'm going to live in a cell for the rest of my life. Things are changing rapidly on this last line. We don't know how long it lasts. It could last your entire lifetime. We have to wait and see. Okay, how do you choose which antibody test to use? Well, okay, you don't actually choose the antibody test that you want, but these are questions you should ask your physician because A, he or she should know this, and B, it will help you psychologically. You want a test that has very high specificity and very high sensitivity. What does that mean? Is it specific to this virus? Or is it picking up other coronaviruses? Or is it picking up some other virus that is a respiratory tract virus? You want to know how specific it is. In a real world, it would be 100% specific. It would only pick up this particular coronavirus and no other coronaviruses or other viruses. You want to know how sensitive it is. Is it sensitive to, I got one virus and I now have a teeny tiny bit of antibody production, like maybe 10 antibodies. Will this test recognize those 10 antibodies, or does this test have to wait until there are thousands or millions or billions of these antibodies? Now, those are silly numbers, but you get the point that you want to find out, is the sensitivity of this test good for those early stage antibodies and very low number antibodies? The FDA's minimums are you should have no false negatives for 80% of the cases, and you should have no false positives in 80% of the cases. So what about the tests that are out there on the market? I have 2 examples here. The Roche test is exquisitely sensitive and exquisitely specific. Abbott Labs has 4 different tests. Some are better than the others. So you want to know, if you're nervous about, did I have this? Do I have antibodies? How can I make decisions because I'm a nervous person and I want data on this? You need to know, how good are your tests? How good is the sensitivity and how good is the specificity? And there is no harm in asking for another one just in case. For example, if you've got a test for an IgM antibody and it came out metza in the beginning, wait a couple of days, because remember, it peaks at day 20 or thereabouts until you get closer to that peak, and then you'll be able to get a better answer. If your test is an IgG, you might not really want to rely on it at day 10, but you could really rely on it at day 30. So you can look and choose, you and your physician, what are my issues? What are my concerns? Pick the test and the time that is best for you to be able to get an answer that makes sense for you. But the big issue to this was you and your physician sitting down, you know your history, the two of you know what's been happening, the two of you know what drugs you're on and what your immune system looks like. Pick the test that will give you the answer that is correct for your time and your concerns. And now I'll turn it back to Brian and for questions and answers.
Well, first, I want to thank all the panelists. I think that was amazing. And you probably answered more than half the questions. So even though this ran quite a bit longer than I thought it would, I think we did directly answer some questions. But I'm going to start with questions. And because there's so many, and there's so many people listening in, I want to ask people to keep their answers relatively short. So I'm going to start with you, Dr. Shadman. One of the questions is about the topic, managing reentry. And what if you're a healthcare provider, if you're a nurse, you're an OT, you're a respiratory therapist, you have these patients, and let me add to that, if you're a school teacher or a preschool teacher, what are you telling these people who are really high risk? If you're a paramedic, if you're a firefighter, what are you telling these people who are your high risk in terms of exposure patients about returning to work?
I mean, this is a very important question, and I actually saw many questions in that kind of talking about the specific type of jobs and situations. I would like to start with an example. When we one of the treatments that most of us in this panel are involved in is allogeneic stem cell transplant. So when we discharge a patient from the transplant service, or when I talk to my patient after they come back from receiving the allogeneic transplant, first few months, of course, things are very strict. And then at some point, we start talking about really the risk and benefit of going back to normal life. And, I've noticed that recently the conversations that I have with my patients are very similar to what I tell them after allogeneic transplant. Really, we have to look at few factors. Number one, again, I go back to the first point of where do you live and how serious is the pandemic or epidemic in your area? That's number one. Number two, what is the risk category of your job? Are you directly in contact with patients who have COVID-19, or are you a healthcare provider working in a practice that maybe in the past month or so there hasn't been any patient with COVID-19? Number three, how flexible your job is. I mean, can you talk to your colleagues and maybe get a position that doesn't put you in direct contact with patients? And a lot of patients actually have that opportunity, and they do get this option. So to make a general comment, yes, in an ideal world, if I have a patient who works directly in an environment that there's a risk of exposure, I would like for them to change their job, stay home, and kind of minimize their risk. In real world, in real life, that most of the time is not happening, right? So if somebody has to work, if they haven't seen their grandkids for 4 months and they live in the same city, can we come up with some recommendations that, while at the same time we follow the principles like hand washing, physical distancing, if the other person or the other group have any symptoms, they absolutely need to be out of the picture. But otherwise, as long as the principles are followed, sometimes some of my patients have been able to go back to work. I have been providing letters and talking to some of my patients, basically employers, and in some cases I've been able to help them kind of change or modify their role for at least a short period of time. I know I'm giving a very general answer, but this is a very general question too. So yes, we would like to minimize exposure. So again, if a physician who works directly with COVID patients, I don't want them to continue to be in that environment. Patients with CLL are considered very high risk. And what I tell my patients is that consider yourself at the highest risk category. For example, in our state, there are phases of individuals going back to a normal, basically, lifestyle. And I always tell my patients, you are in the last phase or category, whatever that is. And after that, we should all remember, this is a situation that we don't know when it's going to end. So at the same time, in my opinion, we have to live, and we have jobs that at some point they're not flexible, and we just need to do our best and use the guidelines and practice all the precautions, and just be careful. And I'm happy to be more specific with the more specific questions, but I think this answers a number of questions that I saw.
And let me say that some of the doctors on the here are going to have to leave because they have to make rounds, but I'm going to try to let it run about 15 minutes over so we can get to more questions for the people who can stay around. But please understand, a number of the docs may have to sign off. Dr. Stevens, could you address a related question, and that's about shielding? What about a CLL patient who has a family member who has to travel, or their spouse is a nurse or a physician? And let me extend that and talk about the children. The children are going back to school now, and they want them to socialize and be in school, or the grandchildren, not being able to visit with the grandchildren and stuff. That's something that Dr. Shadman touched on. So that shielding issue, not just what the patient should be doing, but what their family members should be doing. And do you have to quarantine inside the house? How are you addressing that issue?
I think this is a very important and maybe tough question to answer, because as we've all talked about, there's no set time limit for this. I think if we could tell people, be very strict about social distancing for the next 2 months and then everything goes back to normal, it would be a lot easier. However, there are real situations where your kids are going back to school or your family members have high-risk jobs. And in that situation, your family member needs to be very vigilant about doing what they can to prevent themselves from coronavirus infection. And so if it takes additional education from, especially adult family members, to make sure they're doing appropriate hand washing, make sure they're wearing masks, and they're avoiding as much social contact as possible through their job. Children are a little bit more difficult because it's really tough to teach them how to social distance because that's not in their nature. And so in that instance, if you have children who are in high risk situations, you really just have to do what you can to make sure that hand washing is implemented when they come home from school, making sure that their teachers know that you're a high-risk patient. And so if there's any contact known with coronavirus infection at school, make sure that you're aware of that. So that if you have to quarantine your children from yourself for a certain period of time, you have the most information necessary. But I do think this is an important question, and I think it's a tough one. And each person, if you have specific questions, it's a good idea to ask your doctor about them to see if you can get some individualized guidance for your situation.
Dr. Hansen, another re-entry question, and maybe we can just go through kind of a checklist here. These are the common ones, and there's a lot of repeats on these. The hairdresser or the barber shop, the hotel room, the public restroom. We hear that you flush the toilet and you're exposed to COVID. Outdoor restaurants. Can I have somebody in to clean my house? And which is safer, takeout or delivery? So I'm throwing all of those to you. If you could kind of give us brief checks off on those, yeah.
So yeah, you ran through a lot of different ones. I couldn't even write them down fast enough.
Hairdresser, our barbershop, hotel.
Okay, so let's do that one first.
All right.
So full disclosure, I've been back to get my hair done. And I think, again, it's knowing a little bit about what's happening in your community, what your comfort level is, and what steps the salon or barber has taken to help facilitate social distancing. So where I go, they have huge doors that they keep open. They're keeping it a third full. It's one chair and then nothing for 5 more chairs. I wore a mask the entire time. The person wore a mask the entire time. And I think they really took every step to try to make it as safe as possible, but it's not zero risk. So it's kind of assessing for yourself what you're comfortable with, but also really understanding, have they taken all the environmental controls that they potentially could to reduce transmission?
And what about the public restrooms? What are you telling people? It's all this, it's safe to go outdoors, but if you're hiking and you have to use a restroom or you're at a park, you know, does that take away all the benefits of the outdoor activities?
Yeah, I think, you know, if you need to use the public restroom, you should do it. Hand washing, very diligent hand washing afterwards. I think it's controversial about this flushing the toilet and what risk that is. We do know that we can find the virus in stool samples, but most of the studies, we've not been able to culture the virus from stool. So we think with very sensitive molecular methods, like Dr. Leclerc mentioned, when we're actually looking for the nucleic acid of the virus, the RNA, we can find it there, but it may not be alive and replicating and infectious to others. So I think the act of flushing the toilet is probably not that big of a risk. If you can close the seat and that makes you feel better, that's good. I always keep hand sanitizer in my bag, my backpack, my purse. I also, if you can find, you know, wipes are hard to come by now, but alcohol, hand sanitizers, even using that to touch the handle on the door or the toilet and then sanitizing afterwards. So I think if you gotta go, you gotta go, but being smart about how you approach it, you could probably reduce your risk.
And food issues, the takeout, delivery, it seems like we've moved away from that being a high risk. Outdoor restaurants, you want to just touch on that?
Yeah, I think there's really no evidence that takeaway food from a restaurant is a risk. Again, good hand hygiene. You know, people have asked me too, like when I go to the grocery store, should I clean my groceries? Should I let them sit for 3 days to let anything on their surfaces die? And I think more and more we're thinking that that's probably not necessary as long as you're being diligent about hand hygiene. And then, you know, similar sorts of things in an outdoor restaurant space, you are around other people. Being outside makes it potentially with the airflow and other things more safe, but you can't wear your mask the whole time while you're eating and drinking. So it's kind of knowing what's going on in the community, knowing what the setup of the outdoor seating is, how close you are to someone else, making sure that the servers are wearing masks and potentially gloves. Are all things that you could check into and then gauge that against your level of what you'd accept as risk versus benefit from enjoying a nice meal at a restaurant in your community.
Dr. Hill, I'm going to thank you, Dr. Hansen. Dr. Hill, I'll give you the last kind of re-entry question, and there's a million variations on this. Flying, traveling, you know, what advice do you give your patients? Is it safe? Is it, you know, is it an absolute taboo?
Yeah, thanks for the question. And that's, you know, obviously people are eager to get back out there and to do both essential and non-essential travel. I think given the context in which we're in right now, I would still limit travel to essential travel, especially for our patients with CLL. So I think that's the key here. If you find yourself in a situation where you really do have to travel, I think adhering to the concepts that Dr. Hansen just laid out apply very, you know, well to the travel aspects. It might be a little bit harder to avoid large crowds, but then, you know, do your masking to avoid exposing others, of course, careful hand hygiene. Airports, they've done lots of studies of the high touch surfaces. Just be very conscious of where you're putting your hands, careful hand hygiene, and all of those sorts of standard approaches. In reality, in some ways, given the hypervigilance that our society as a whole right now is paying to hygiene, masking, social distancing, physical distancing, one could argue that the overall risk in someone getting onto an airplane right now with trying to be spaced apart as well is probably relatively low, that you're actually going to get exposed if you're doing all of the things that we're talking about. It might even be lower for other types of infections that you're exposed to when you travel and you have an underlying immune condition like influenza. We're seeing those rates drop. So, this might be a time when we're actually theoretically at lower risk just because everyone is being so cognizant and aware, but the risk is still there, and getting COVID-19 is a risk. So I think the risk is low. If you have to travel, I think you can do it, taking all those appropriate precautions into place.
I'm going to switch gears and ask you, Dr. Hill, a follow-up question. There's a lot of buzz about vaccines. Are they going to work in CLL patients because of our compromised immunity? I know this is an area of research that you're involved in.
Yeah, there's obviously still a lot of talk about that. I think we haven't made a ton of movement even since the last time I was on this venue talking to you all. There are some exciting phase 1 and starting to be phase 2 results showing that vaccines in healthy volunteers at least appear to be immunogenic, meaning that they can stimulate an immune response that we think can prevent people from infection theoretically, and they appear to be safe as well. So there's lots of different vaccines still in development. To my understanding, none of these have been tested so far in cancer patients. We have lots of experience using vaccines like the influenza vaccine and other vaccines in patients. Typically, we avoid giving vaccines, whether they're live or inactivated, to patients that are actively receiving chemotherapy. For things like ibrutinib and some of these less aggressive forms of chemotherapy, sometimes we do consider still giving vaccines, and certainly flu vaccine we'll give regardless. Most of the time it's safe. And even if a patient with CLL or another underlying immune compromising condition doesn't have 100% response to the vaccine, as robust as a healthy person, there's still probably some degree of response, and at least some patients may respond more than others despite the underlying cancer. So those even minimal responses can reduce the risk of both getting it and the severity of the infection if you get infected. So I think any vaccine that is inactivated and safe in our patients is something that we should be considering in patients with CLL as well.
Thank you. Dr. LeClaire, one of the questions is, you talked about the testing. Is it going to be less accurate in CLL patients? Because a lot of us don't have low levels of IgG and IgM to begin with. Does that affect the ability of the test, which already is iffy in some of these tests? Is it going to make it even less valuable in a CLL patient to understand the test?
And the answer to that, as I'm sure every physician here is thinking in their heads right now, it totally depends on the patient. There are CLL patients that you have that are on watch and wait and have minimal changes to their immunoglobulins, and they're going to do just fine. And that test is going to do just fine for them. It might be a little bit weaker in the beginnings, like takes a little bit longer to get the immunology really functioning, but those tests will be fine for them. When you're looking at someone who doesn't have the capacity to make even semi-adequate numbers of immunoglobulins, then yes, that's going to be a problem, and you may have to go to a much more sensitive test that's going to take longer and that might be a little more difficult to find, but that you will have that capacity. But it's got to be done on a patient conversation basis with their physician. You know what I look like, you know what I function like. I haven't had a cold in 4 years. Whatever this CLL is doing to me is not doing anything in that area. That's a totally different patient from the one who says, I can't seem to get over my colds. I just get one and I get another. That's a totally different level of immune function, and that has to be discussed from that point of view. So yeah, it might cause problems, but not with everybody.
Dr. Stevens, I'm going to follow up on that and get your opinion on this, because I think there's been some controversy in the CLL space. Is whether it makes a difference, whether if you're in watch and wait, even if you're monoclonal B-cell lymphocytosis, the pre-CLL, whether you're in active treatment, whether you're on this drug or that drug, whether you're in a remission, because some of the data that I've seen suggested that if COVID is a risk in all of those circumstances, even the treatment naive patients who've never been treated. So while it may protect against other infections, we're not so sure. I just wonder what your take on that data. I know it's very early.
Yeah, and it's hard to speak specifically about coronavirus due to the lack of data available. However, we know with lots of other infections that people at all parts of the spectrum are going to have a decreased immune system. And that includes patients who have had a lot of treatment for their CLL, patients who are previously untreated, people who have been on the watch and wait for years, and even people with monoclonal B-cell lymphocytosis. And so any of those categories, I wouldn't consider yourself safe from developing the coronavirus or serious complications thereof, because even patients with monoclonal B-cell lymphocytosis have an increased rate of infection over patients without monoclonal B-cell lymphocytosis. And so it's hard to say that any of these populations of people are safe from coronavirus. The other factor that comes into play also is a lot of people who have these disorders are in their 60s or 70s, which has been shown to be a risk factor to start. And a lot of people have other medical conditions such as diabetes or high blood pressure or kidney disorders that are also going to increase their risk. So I think in general, this is a very high risk population and should be cautious as such.
One follow up on that, Dr. Stevens, is there a time that a CLL patient is no longer immune compromised, or when we get the diagnosis, and probably before that we're immune compromised and that never changes? Is there a time we can say, I'm...
For the most part, I would say no. There's no certain part that you're not going to be immune compromised. Now, there are some data about patients who are treated with ibrutinib, and there are some data that potentially this can increase your immunoglobulins, which may then decrease your rate of infections. And on clinical trials of CLL patients treated with ibrutinib, they found infectious rate might be a little bit higher at the start, but after years of therapy, there are lower infectious rates. And so I still would not count somebody who's on ibrutinib as a normal immune system, as normal as somebody who doesn't have CLL, but I would say there may be treatments that cause differing reduction in the immune system.
And I think to your point is that while we're all immune compromised, to Dr. Leclerc's point, there's a spectrum there. And if you've just had heavy duty chemo, that's an issue. The less CLL you have, often the less immune. So staying on a drug that controls your cancer, I think is going to help. Dr. Hansen, I'm going to give you this one and sort of to look at. What should we be looking for to say it's safe to come back into the community? We've talked, Dr. Shadman talked about the rate of disease in the community. To explain a little bit about herd immunity, and maybe are there any medications that are out there that are getting you excited? The two that seem to have a buzz right now are dexamethasone. We just heard some good news on that. Remdesivir, that might have a role to play. The BTK inhibitors, there's some hints that they may help. What is it going to take for you to be able to say, it's never going to be 100% safe, but we've turned, so I started with the herd immunity, and then if there's any drugs or anything that I left out or that you're excited about that are saying, we're starting to see a glimmer of light here.
Yeah, I guess I'll take the herd immunity issue first. I think that is a really far way off. Everything I've read from experts in this space is that it would take about 60 to 70% of the population having been exposed and immune to confer herd immunity. And even in the highest prevalence areas like New York City, it's nowhere near that. So that is a ways off. I think what excites me most is the potential for a vaccine that's effective. And that may be a ways off as well. You know, Dr. Hill can speak more to timelines, but from what I've read, the most optimistic would be the end of 2020, maybe, to have a candidate that's available. In terms of treatments that are exciting me, nothing is blowing my socks off quite yet. I'll say remdesivir is probably the one with the most data for it at the current time. The FDA has granted it emergency use authorization. It's an IV medicine only though, and so it's reserved for patients sick enough to be admitted to the hospital and potentially requiring supplemental oxygen. But we have learned, and we mentioned this earlier, potentially giving that sooner rather than later would be the biggest bang for the buck. You specifically mentioned dexamethasone. I'm not too excited about that. I have not read the papers specifically that have come out recently that potentially it was a benefit for individuals who were severely ill and on a ventilator with severe pneumonia and inflammatory kind of sequela from the virus. There have been some reports that it helped in that setting, but we've looked at dexamethasone and steroids for many, many other lung processes that end in this process called ARDS, or respiratory distress syndrome. In them all, the steroids have never really done much. So I'm skeptical that COVID is not going to be much different. The other therapy that, you know, along with remdesivir, I think has potential is convalescent plasma. So it's essentially a blood transfusion from a recovered patient. So someone gets COVID, they develop the antibodies that are detectable with Dr. Leclerc's assay at a certain level. They're felt to be protective. You take them from the infected individual and then transfuse them into someone with a new infection. Maybe that could help. There's some observational studies that suggest it can reduce severity and the duration of illness, but again, none of them are randomized or controlled. It's all observational, so there could be some confounders there. But at least what's been done with the convalescent plasma up until now in registries of over 5,000 patients who've received these transfusions, they do appear pretty safe, that there are few severe side effects. So it could be something that's considered for someone who's sick enough to be in the hospital again and requiring pneumonia or oxygen. And I think there are some studies actually looking at convalescent plasma as what we call post-exposure prophylaxis in healthcare workers if they were exposed to a COVID patient not wearing their appropriate PPE to potentially get that antibody boost to see if it could be preventative. So stay tuned for that. I think that's an interesting approach there. I could go on and on. There's a lot going on in this space, but for the sake of all the other questions I know you have, maybe I'll stop there unless you have another specific intervention you were interested to hear about.
No, I mean, I have a million others, but I think in the interest of time, and we're over now, and I want to be respectful to our audience and our faculty, but maybe I'll ask people just to give kind of a quick 1 or 2 minute summary in terms of any final thoughts that you have. Can I start with you, Dr. Stevens, and then go to Dr. Shadman and kind of run through that?
Sure. I think it's important to understand that although social restrictions are lifting, that the pandemic is not over. I think there's a lot of hope out there for vaccines and new treatments. And I think each patient should really take an individualized look at what returning to normal life looks like for them. And I think a lot of employers are willing to accommodate patients who have decreased immune systems.
Thank you. Dr. Shadman?
Yeah, I would say COVID-19 is important. We talk a lot about prevention, and we don't have much to offer in terms of treatment right now, but we covered all the preventive strategies. But remember, CLL is also important. So as a CLL physician, I would feel responsible if my patient has any complication related to not receiving the right treatment for their CLL. So I want to make sure it doesn't matter if if you're a patient who's on a watch and wait basically strategy, or you're post-treatment and currently off treatment, or if you're getting treatment, please make sure that you have a very close communication with your physician. I have had, unfortunately, patients who either are on treatment and refuse to come back to the clinic visits despite my request, or I give you the example of a patient who didn't start treatment in time. So we want to make sure that we use all the measures to prevent coronavirus, but there's another active problem, and that's CLL. We have to make sure that we're not missing the opportunity for that.
Dr. Hill.
Yeah, I think the only other comment I wanted to make is that, we certainly appreciate that this is an anxious time for many people. Perhaps it was easier in the early stages when the rules and the, guidelines and recommendations were pretty clear to just stay at home, be isolated. I think now that there's all these possible stage, re-entry criteria might make it even more challenging, and there's more deliberation. Should I go out? Shouldn't I? At the end of the day, I think, be pragmatic about it, use a lot of the approaches that we've talked about today, and just make that decision with yourself to say, what are you comfortable with, what aren't you? And then just stick with it instead of deliberating for each little thing. Perhaps that might, just help people say, all right now I'm just staying put. And I think that's totally fine. And then just the other concept around how to protect yourself is very similar to what we say in other cancer patients and with transplant settings. Try to build that bubble around yourself as much as you can. That's going to be harder as people go back to work and kids go back to school, but as much as you can, build that bubble of protection around you as much as possible. Yeah, I think that's all I really have to say.
Dr. Hansen.
I don't have much more to add than what's already been said. I'll say there's so much information out there about COVID-19, and it can be overwhelming to weed through it and to figure out what's accurate and what's not accurate. That's why I think forums like this are so important to really be able to talk about what has data to support it versus what is, just common sense given the facts. And so I appreciate that the CLL Society is doing this. I think this is a super important resource for patients. And then getting to an earlier point, if you have specific questions about your own situation, feel free to reach out to your doctor to discuss. We're happy to field questions, especially as it relates to return to work.
Dr. LeClaire, I'll give you the last word here.
Well, I'm going to say the same things that I've always said. There is a huge amount of information out there. Some of it's actually real. So here are my 4 rules, and it's the 4 rules that I follow for me and for my family. If I want to know anything about the science, I listen to Anthony Fauci. If I want to know anything about restrictions and quarantines in my area, in my town or my state, I listen first to the mayors and the governors, because they're the ones who are dealing with CDC and their own public health agencies to keep track of this thing. If I'm talking about me, I want to talk to my physician. The 2 of you are the 2 people who know the best about you. They know everything about you, down to your genome. So if you want to ask a question of somebody who knows you well enough to give an answer. And finally, and I think we've all talked about it today, the last decider is you. No one's going to make you do anything. You have to decide based on what the science is telling you, or the society is telling you, and your physician is telling you. You have to decide what is best for you, not for the person next door, not for what does one of the ads say, the cousin of the ex-boyfriend of the ex-boyfriend of the, or something like that. You and you alone. So listening to things like this, speaking with your physician, the best things you can do.
Well, I'm very grateful to our panelists, our faculty. I think we really covered a lot of material, and we could have kept going for another hour. I appreciate you sticking on for another 15 minutes. There you go, Dr. Shadman, you showing us the way here. I think we're going to do some questions. We have a final survey that we're going to do here. And we can see here that there's I understand the precautions. I think it's more strongly agreed this time. Last time there's only 38% strongly agreed. So I think there's more clarity on that. I think in the next question, it's still a pretty similar spread in terms of the current pandemic. And let's see, and this concern stays about the same. Our greatest fear is getting the virus. And let's take a look at social distancing. And that number went up from 43 to 58. So I think we're a little less ready to jump into the world right now. And again, I want to thank our sponsors, AbbVie and AstraZeneca, who underwrite this but have no say in what the content is, who the faculty is, what questions get answered or don't get answered. So we appreciate them just bringing the raw information to you. And I think we are going to do this again, but I don't know quite when. We'll probably wait a little bit till we have more data. So thank you for attending. The CLL Society is a 501c3 not-for-profit, and we're dependent on your contributions and donations. So if you can, and we know this is a difficult financial time for a lot of people, but if you can help us in any way, please do so. There's a short survey that we need for your feedback, because we have to let our sponsors know what we're doing right, but we also need to know what we're doing right, what we could do better. We really do listen, and we do pay attention to that. And we are posting updates several times a week on our COVID-19 pandemic page. And some of the people that are on this page have contributed to that and written up articles for us. We try to get the top people. The CLL Society has been involved in research with a number of the panelists here in terms of looking what patients are doing, and that research isn't stopped. So we're very grateful for your attendance and your attention to this, and very grateful to the faculty and our sponsors. Thank you all for attending. I think we're good. Yep. Thank you, everyone. And I think with that, unless there's another slide, I'm going to sign off.